Good morning, everyone. We're about to get started here with our next presenter, Dr. Qualish, and I'd like to say good morning to everyone who's joining us on UroNurse. Dr. Suzanne Qualish has been working as a nurse practitioner for almost 25 years. Her career has focused on improving the care of men by focusing on raising awareness of men's sexual and reproductive health needs and emphasizing preconception fertility care for men. She has been engaging in clinically based research that quickly translates to improvements in their care. Her present research interests include chronic, pelvic, and genital pain issues in men and psychosocial characteristics of men seeking fertility care. Her clinical focus includes chronic pain issues in men and men's sexual and genital health needs. So please join me in giving a warm welcome to Dr. Suzanne Qualish.
All right. Well, good morning, everyone. It is really an honor to be here. I'm a huge fan and supporter of UroNurse and all the work that Vic and Chicago Metro have put into it. So it's really a great joy to be here today. We're going to jump right in and get started. And these are our objectives today. But as you can see, maybe our real objective should be like my Great Dane and just to go back to bed and be warm. It sounds like you're as cold as we are today. And but we're still going to go ahead and we're going to talk about some relative scrotal concerns for men. So these are some slides we're going to go through super fast because these are in the handout, just to remind you that the scrotum sometimes gets a bad rap for being a very simple structure, but there's really a lot going on there and a lot of structures that really influence some of the things that patients are concerned about and certainly also the things that we need to be concerned about. So we have a complex system of tubules that are in the testicle and the epididymis. We have some male physical exam specifics just for your reference. We're not going to read through these slides, but these are something to refer back to. Same with this slide. And we'll pull these in as they're relevant as we talk about some specific scrotal conditions. Moving on to the history and physical. For many of you, this is very old hat. You know this, but we're going to run through it anyway to just kind of balance the scales and make sure everyone's on the same page. When we're talking about things with the scrotum, what we want to do is really make sure that we query some of what I call habits that can really be detrimental to the scrotum and need to be thought about when folks come in complaining of scrotal pain, testicular pain. And these are anything that would provide some trauma, some significant, some less significant to the scrotum. We have a kind of a running, I don't want to say it's a running joke, but a running awareness in our department, January, February, that this is when a lot of our snowmobile pelvic injuries come in. So we know that that's a significant factor at this time of year for us. We're also looking for any condition that would affect how the development or the structure or the function of the testes and the penis could be effective. So these would be things like undescended testes. And any history of surgery along that same vein that may have affected the structure or function of the structures in the scrotum. Anytime there's a scrotal complaint, it is also very important to query that sexual history. We want to make sure which direction we focus our exam, we focus our evaluation, and also family history, just to round that out in terms of history taking. Key points to walk away from this section really, though, is asymmetry is normal. You may have been asked about patients who are concerned that their testicles aren't exactly the same shape and size or hanging exactly the same way. That is completely normal. In fact, I always come back with the person who has perfectly symmetrical testicles is actually the outlier. Wide variations in size and body habitus can influence how easy the exam is. Sometimes it's not possible to do a thorough exam with the patient standing up. You really do need to lay them down. And there can be social and cultural barriers. In this day and age, I think we're all very aware of that. And sometimes patients are not comfortable with a gendered provider and prefer a same gendered provider. And it is important to accommodate that whenever possible. Moving on to the key points of the exam itself, we're looking for inspection. Again, we're not going to spend a lot of time on this simply because this is the first point. You're really looking to see how everything presents. And we're always looking for scars because remember, people are very well-meaning, but they forget to mention that they had surgery. So we're always looking for scars. We are not percussing and we are not listening to the scrotum. Patients find it very confusing if you come at them with a stethoscope. Although in the context of a suspected hernia, that is something that you can try. And palpation is really where sort of a lot of the information for the exam is going to come out. Again, these slides we're going to go through relatively quickly because they are here primarily for a reference for you. And we'll talk about things as with specific kind of specific entities. Inguinal canal, I always put this one in here. It seems that I have a lot of students who are not super familiar with this exam. So again, this is here for your reference. And then some examination specifics. Average testicle size here. I don't know what your experience is. I get asked that a lot. I'm always able to rattle that off and just let folks know that they fall in that range of normal. And also the ultrasound. If you have an ultrasound report that talks about testicle size, that can be very helpful also. Epididymis, these are some normals and abnormals that you may find. It's always worth really trying to focus and find that epididymis during the male exam. Vas deferens and spermatic cord, same thing. Takes a lot of practice sometimes to find subtle variations in this. So don't feel too bad if this is not your forte. Lots of time to get good at this piece. So now we're going to move into the fun stuff. When to be concerned. Now there are when you are concerned, right, as a provider or as a staff member, and then there's also those things that our patients are concerned about, and they're not always the same thing. And we'll go through some of those because it can be a very reassuring exam for men. We're going to start right out of the gate with things that fall into this acute scrotum category. And these are things that are actually really very dangerous, very painful, and need some attention very acutely. And you can see they fall in some different conditions, things that are ischemic, things that are related to trauma, things that are infectious, and we'll go into some of these in a little bit more detail. Some other categories, some specific inflammatory conditions, although I have to be honest, this is in terms of some of these things, they're really quite rare. Hernia, always consider hernia. And then some things that are acute on chronic, we say, a spermatocele that formerly wasn't painful, but is painful, hydroceles, tumors, and varicoceles. So we'll go through some of these. Testicular mass, our clinics allow patients to self-refer. This is a relatively common reason that patients do self-refer for testicular mass. And so when we see that, we assume it's either torsion or a tumor, and we get them in right away. That's our clinic protocol. And because those are the things that can be very, very dangerous. Although I will give you in terms of testicular torsion, this is something that is acutely painful. And so for those in the audience who are listening who may be taking phone calls and triaging phone calls, if you have a patient or a family member or a partner of a patient who calls and says, my male person has acute, crippling, nauseating testicular pain, don't bring them into clinic. Document and tell them to go to the OR, or the ER rather, because they may need to go to the OR. So it's really important that we don't delay care anytime you have a suspicion of testicular torsion. It is much more common in males, as you can see here. And it's commonly seen in younger men, although that's not, that this should always be part of the differential for acute onset, really significant testicular pain. The testicle twists on its arterial supply, and so the blood supply is lost to that testicle. You will see swelling and tissue necrosis after 6 to 8 hours, and it also compromises the venous flow. So this is a very acutely painful condition. And again, we know that it's a little bit more common with teen boys. The pain will localize to the affected testicle. It can radiate in that typical pattern up in the inguinal region, sometimes to the flank on that side. Physical exam will show asymmetric scrotal swelling, although if you're approaching that 6 to 8 hours, you may actually see pretty much generalized scrotal swelling, which can make it a little more complicated to sort. The testicle may be somewhat elevated. Again, you're twisting it on its cord, so it's going to lift up a little bit, and it may sometimes be sideways as well, although I would not use those as the only diagnostic things. And usually there's just a lot of swelling. And you're not going to see that normal cremaster reflex that can move the testicle up and down. This is one of the 2 true urologic emergencies that we're going to talk about today. And what that means, again, they don't need to come to clinic. They need to go to the ER. And these are the things that can potentially result in lawsuits for a misdiagnosis or delayed diagnosis. So just be aware of that. The picture here gives you some ideas of the different presentations that you may see. Immediately, they will get an ultrasound. They may immediately get a surgical exploration and attempts to save that testicle. And beyond 12 hours, it's really sometimes not possible to save the testicle. We're going to move on to penetrating and blunt testicular injury. So a little bit more uncommon, but it's out there. And you can have testicular rupture. So the testicle is covered in thick connective tissue, but it is possible with enough pressure or enough trauma to actually rupture that connective tissue. Usually we see this as a result of blunt or penetrating trauma. And again, this is a condition where we really want to do pretty quickly surgical exploration to categorize the injury and to also see if it's possible to repair it. Blunt testicular injury, wild incidents, like no one really knows what this is. It's going to depend on the forces. Was this a crush injury? Or as I suggested before, was this a groin versus, snowmobile injury? You're going to see, again, a lot of swelling, a lot of tenderness, a lot of ecchymosis. Those are kind of the things that the scrotum does when it gets kind of put out of its normal environment or subjected to any kind of trauma. Sometimes on ultrasounds, you'll see reports of scrotal wall thickening. Sometimes you can even pick that up on exam. Again, we're looking at an emergent ultrasound, and the ultrasound will help us categorize exactly what the nature of the injury it is. We're looking at a surgical repair here, and sometimes the testicle itself may be okay, but it may have created such a significant hematoma in the scrotum that needs to be drained in the operating room. So the ultrasound here is really key to help categorize what's going on. Penetrating injury, again, and we're looking at surgical exploration. Most of them can be repaired. We're only faced with making that choice for an orchiectomy if there's really a lot of damage to the spermatic cord, so to the vasculature that's feeding the testicle. So those are all intraoperative calls, not something we would make clinically. So we're going to move on. We're going to meet our first patient of the morning. He's a 22-year-old male with an 8-month history of left testicular pain that began after he was kicked during a martial arts class. Chronic achy pain that's never really resolved. Previous physical examinations, because we're looking at his chart, were pretty unrevealing. He's been treated with the typical course of anti-inflammatories, antibiotics, some narcotics, but he's never really improved. So is this a condition that we should worry about, or that this is just something that the patient's worrying about, as we kind of alluded to earlier? Well, his pain's been slowly getting worse, so we really need to spend a little bit more time figuring out what's going on. If it was really something that we didn't need to worry about, his pain should be getting better with time or better with the use of anti-inflammatories. And he's complaining that his testicle feels a little heavy as well. He only reports pain with the left side, and we get an ultrasound, and really the key here is that it shows a mass that's suspicious for malignancy. So testicular tumors are the number 2 thing here that we need to worry about as clinical staff. It's relatively uncommon. You can see some numbers here for 2022, less than 10,000 cases, and really good survival rate for this particular type of malignancy for 5 years. We're really good at finding it. We're really good at treating it regardless of the stage of presentation. The risk now is 1 in 250, and average age at diagnosis is 33. A lot of times people are very surprised when I bring that out, because I think we have this idea that this is a kind of a young man's tumor, and it really isn't. It is a younger man's tumor, but it's not a teenage boy or even a young 20s tumor. It's really something that once you hit that age 30, you hit into that average age. And we do have very good guidelines from the AUA that offer treatment for that. So again, very successfully treated. Greatest risk factor for this is undescended testicles or cryptorchidism. The incidence for these men who have that history is 7 to 10%, particularly with unilateral and bilateral testes. We do a lot of screening and early detection have decreased the mortality from this malignancy. So men are presenting a lot earlier. And the advantage of this is that these are men who are doing self-exams, and it's something, when they find an abnormality, it drives them into clinic. And yes, sometimes they're identifying their epididymis as opposed to a testicular tumor, but that's okay because it's driven them into clinic for a formal evaluation. And I will say that this is one of the things that the internet as a whole gets right. It has really emphasized and taught men to do testicular self-exams, and so we really do catch these tumors at an early stage in most cases. History can typically include painless swelling of the testicle, and sometimes epididymitis. I hate to tell you how many cases I've seen where patients were given antibiotics and without a physical exam or without an ultrasound, just given antibiotics over and over until someone actually gets an ultrasound or they self-refer to our clinic. A lot of times you can feel distinct nodules, sometimes not. Sometimes it's just a matter of that surface of the testicle being slightly different on physical exam. I've also seen patients who have had older patients sometimes who note like a little bit of a trauma to the testicle, like maybe their dog kind of ran his head in that general area and the aching is just never resolved. And rarely it's acute pain. That's not a very common presentation. And we also have to consider the fact that because there is a mass inside the testicle, that it does contribute to subfertility or infertility for some patients. So again, we want to make sure that we're doing some very thorough and sometimes interdisciplinary counseling for these men once they're diagnosed. Physical exam, distinct mass. If you've ever felt someone with a testicular tumor, you know it's not supposed to be there. It just doesn't feel right. Ultrasound is always going to help you sort this stuff out. And you want to go on to inguinal, supraclavicular, and axillary nodes for palpation because that's the pattern of spread. Abdominal exam can demonstrate bulky retroperitoneal disease. In 22 years, I've never felt that, and you would have to have a pretty thin gentleman to be able to make that part of your definitive exam. And in advanced disease, we can see wheezing and gynecomastia as well. Scrotal ultrasound is the key here. And as an aside, the scrotal ultrasound is your best friend. It's essentially a fifth vital sign when you're talking about anything that's going wrong with the scrotum. And the advantage to that, I just want to say, order the ultrasound. If you have any uncertainty about what's going on, order the ultrasound. As of right now, and knock on wood, no prior authorizations or any hoops that you have to jump through for a scrotal ultrasound. It's quick, it's easy, and most of the time it gives you the answer that you need. We're looking at some labs for this as well. You can always do a complete CBC to rule out infection. Infection can mirror the presentation of testicular tumor, and then the classic tumor marker triad listed there that we're doing to kind of help us sort what type of tumor it is. Chest x-ray, CT scan of the chest, abdomen, and pelvis. Usually those can be done in anticipate, prior to surgery for staging. Just a couple pictures here to give you an idea of top is just a, kind of a smaller tumor that's just starting to break through that connective tissue shell around the testicle, and then the bottom picture there is, a fully infiltrated testicle. So it's these are things that are finesse. Some of them a little bit of finesse physical exam findings that are always substantiated by the ultrasound. We should refer to urologist or a urologist who does this particular procedure, depending on what your location is. We always remove the testicle. The standard of care is not a biopsy, it's complete removal of the testicle. And so that is a big counseling point as well for men who come in just thinking they might have an infection, and then you're counseling them that their testicle is about to be removed. So it's a big counseling point. And we really do require that to get a full pathology diagnosis. And this is where you want to introduce the idea of sperm cryopreservation. If they have not had a vasectomy, if they are considering family building or adding to their family, this is a really important conversation to have. Again, if that's not something that your particular facility or building offers, please try and offer that somewhere in the neighborhood for them. So we're going to move on to hydrocele. This falls in the category of things that patients are concerned about that we know tends to be benign. This is just fluid around the testicle, in that connective tissue around the testicle. And these are common in newborns that usually resolve, but we do see them all the time in men, adult men. Not entirely clear sometimes why this occurs. We've all seen the patients who have it after an infection or after some sort of trauma to the groin or something. And it's just a matter of fluid collection, that either fluid in the scrotum that production outpaces the ability of the scrotum to reabsorb it, or the scrotum itself just no longer is functional in terms of reabsorbing it. It is really not dangerous. Can it be painful? Yes. Does it present heaviness in the scrotum? Yes. Can it create some significant discomfort depending on what their work is? Yes. And again, it can be reactive after an infection. And in that case, it usually resolves after 3 to 4 months, and so does not require any surgical management. This gives you an idea of just some of the different types or different presentations for the hydrocele. And on physical exam, it's usually pretty obvious that there's an asymmetry in the scrotum. A lot of the times you can't feel the testicle, and that's really the marker between a spermatocele, which is a fluid collection in the epididymis, and a hydrocele. If you can feel the testicle, it's going to be a spermatocele. If you can't really sort out and feel that testicle, it's going to be a hydrocele. Sometimes if you put some pressure, or patients will tell you that towards the end of the day, it seems to be a little bit larger because of this transfer of fluid from the abdomen or from the scrotum. And that's when the ultrasound tends to be really helpful, because that change from morning to evening sounds a lot like a hernia. And so the advantage of getting the ultrasound is to really help sort that out, because sometimes that can be a real challenge on physical exam to sort that out, to be 100% confident. Fluid is usually clear, so that you can shine a light through the scrotum, and it has a red glow. We have a picture of that in a second. And again, the ultrasound will confirm that for you. Do we need lab studies? Not usually, not unless you're planning to send someone to surgery, and then you would do whatever your facility requires in terms of typical pre-op labs for that age of a patient. And, it's remarkably hard to find good pictures of this transillumination. So it's not a very good picture, but it gives you the sense of what's going on. Patients love when you do this. You turn off the lights, you get a flashlight, and you make their scrotum glow. And if you have students and you have a hydrocele, it's always a great physical exam point to demonstrate to a student as well. And the reddish glow is good. You want to see that reddish glow, because that means it's just that clear serum fluid that's in there. It's not anything, there's not debris. If it doesn't transilluminate, that means sometimes it's a tumor. So the glow is really good. And this is just a kind of different version of the same thing. Asymptomatic adults, or adults who are not really considering surgery, are not bothered enough to consider surgery, you can observe them indefinitely. I have a panel of guys that come to see me probably every 18 months just to check in and reestablish that if there's any new options from surgery. So they come around every 1.5 years or so. You can aspirate. There's a lot of disagreement, I think, about aspiration. We don't aspirate at our facility. And the reason for that is surgery is definitive. Aspiration is not. We prefer to offer patients definitive management. And if your technique is not perfect, is not pristine, this is serum. The fluid there is serum. And so it is like a really fantastic place for a bacteria to grow really fast. So if your technique is not great, you really have a high risk of infection with this. However, having said that, if there is somebody who has a large hydrocele that needs a catheter, perhaps for another reason, and it's really difficult, there are contexts in which we at our facility do embrace aspiration. But as a general offering for treatment, we do not offer that. Hydrocele surgery then is a relatively minor procedure, relatively straightforward outpatient procedure. And the real complications from that are going to be hematoma and infection, much as you would expect. And then if those are not addressed quickly, you can actually have some damage to the other scrotal structures. This is just to give you an idea of what that looks like. Now we're going to meet our second patient of the morning. He is a 29-year-old male who's been referred for chronic genital pain and chronic testicular pain, no other history. He's been seen by a bunch of providers over the last 3 years. He reports that it seems to become worse the longer he's standing. It interferes with his work as a personal trainer. And from the records that you've been able to read and from his report, nobody's been able to find what's wrong with him. Referral paperwork reveals that he's been labeled as a malingerer and a drug seeker. He's been treated with anti-inflammatories, antidepressants, narcotics, and really no relief from these medications. However, we give him a meticulous physical examination, and we find that the pain is located over the left spermatic cord, not the testicle, and it is consistent with a slow-filling varicocele that we identify in exam. So this is a conglomeration of several patients that I have seen who've been referred with a similar history. This is just to emphasize the fact that the physical exam piece here is huge. I'm going to get up on a soapbox for just a second here. I have seen so many patients over the course of my career that are referred to urology without ever having a genital exam. So the genital exam is so important and really helps sort patients. We know that. You're here because you have an interest in urology. And we know that the physical exam really helps figure out what's going on and what the next step is. Varicoceles are present in 15 to 20% of men. It is a variation of normal. Of that 15 to 20% of men, very few of them have pain. But for ones who do have pain, it's real, and it is varicocele-related pain. This is a very similar mechanism to varicose veins in the legs. The internal venous valves just are not working as well as they could. It is a gravity-related phenomenon. So you're going to hear stories that this is worse pain at the end of the day. It can heat the scrotum. It can change the blood flow. It can change the hormones. These are all things that influence whether or not they may have some fertility-related issues. And for some patients, if the varicocele is bulky enough, you can actually affect the function of that cremaster muscle, so the one that pulls the testicle up and down. Most of the time, men are asymptomatic. We find these all the time during exams for vasectomies. But patients may notice a dull ache, particularly a dull ache after exercise, particularly if they're doing a lot of exercise that causes them to contract their core, or long runs, or sometimes long cycling. Possible semen analysis changes. And then there is a subjective grading system here that you'll see. Grade 3 is the classic bag of worms that you read about in assessment textbooks. Physical exam, we want to compare the patient standing when that varicocele is going to be draining, lying down, because we want to make sure that varicocele empties. Ideally, we want to be in a warm room. We want to have the patient valsalva or bear down to try and force some blood into that venous plexus. And you can see a atrophy or size difference between the right and left side, usually right and left sides of the testicle. And sometimes that's an important key point in getting surgery authorization. This is just to give you an idea. The one side there is how it looks intraoperatively, and then how would it look clinically. So that's definitely the bag of worms. Conservative management, if this is the first time they're having any discomfort from it, we recommend anti-inflammatories and supportive underwear. There's so many types of supportive athletic underwear for men out there now. Usually they can find something that helps increase their comfort level. We can monitor a semen analysis if they're not really interested in that fertility piece, or the fertility piece today. We can monitor that semen analysis to see if they have any ill effects from the varicocele, and then we can always offer varicocele surgery treatment versus embolization through interventional radiology. So we have some good solid treatment options that are out there. We're going to move on to a thing that I think this falls into that gray area of we should be concerned and patients are concerned. So it's both, depending on the specific cause of it. Lots and lots of follow-up from the ER for epididymitis. Really a much lower official incidence than you might think from the number of ER referrals. Most common in men aged 19 to 40. Caused by spread of infection from the bladder, the prostate, urethra via the vas, and higher risk for uncircumcised men, men with catheters, spinal cord patients, enlarged prostate, recent instrumentation, or prostatic surgery. So this is where it goes back to that idea of the history piece can sometimes really help figure out where to go with your evaluation. A lot of the times, because for true bacterial epididymitis, it's uncomfortable. We've all seen these patients. So you can treat statistically based on age and based on sexual habits. So again, that the sexual history piece becomes really important in this context. In cases where it's associated, or the culture points to a sexually transmitted disease, the exposure can significantly predate the development of epididymitis. That's an important key counseling point for people. We want to know if they have a history of vasectomy. If you have a history of vasectomy, your epididymitis is not bacterial. You do not need antibiotics, right? Because that connection to the outside world has been disrupted. True bacterial epididymitis will have a sudden onset over 24 to 48 hours. And so there is significant overlap with testicular torsion. So this is where that history and exam piece becomes really, really vital. In the case of epididymitis, the complaints will peak 24 hours after onset in most cases. So the torsion is going to be a little, right? We're looking at 6 to 8 hours, really, right? So swelling in the scrotum can be unilateral or bilateral, more commonly unilateral. Can decrease with elevation of the scrotum, although I would not rely on that as the only diagnostic indicator. And sometimes men have urethral discharge and kind of the complaints that we would expect to see with an infection in that area. Pain will localize to the affected epididymis. Sometimes it's really impossible to even get a good exam because it's so painful. Epididymis will be swollen. And this is where, again, the ultrasound is such an important adjunct to your own physical exam skills. And we're talking about Prince sign again, urethral discharge, and the reactive hydrocele, because it's just the scrotum's way of responding to this incredible inflammatory insult. Ultrasound will help. Usually, again, we don't need lab work. The caveat to that might be in the case of spinal cord or other neurologically compromised individuals where you don't have all of the normal kind of checks and balances, and they may actually be further along in the process than a normal sensate man might be. I always teach my students to consider the prostate as a source of infection if the male has been referred for repeated or chronic epididymitis. The prostate, epididymitis antibiotic course, 7, 10, 14 days, and that is not enough, right, for a prostate infection. So if this infection has migrated from the prostate, 10 days, 14 days is going to make you feel better, but it's not going to knock out that infection in the prostate. So always kind of put that in the back of your head for these men who have chronic epididymitis, that and the history of vasectomy. We're going to follow antibiotic treatment according to the current CDC guidelines for STIs. Always throw anti-inflammatories at them. We want to make them more comfortable as quickly as possible. Any kind of symptomatic management that seems to work for them, supportive underwear, loose underwear, ice, heat, whatever works. And then depending on what your state laws are, you may be able to provide antibiotics for their partner. If it is left unrecognized and untreated, it can progress to an abscess. And again, this is much more common in men who have some decreased sensory condition like spinal cord in particular. So we want to make sure that we can identify this whenever possible. Now, kind of, this is the big sort of grandpa of them all is Fournier's gangrene. If you are lucky enough to have seen a case of Fournier's gangrene, you will never forget. If you are not lucky enough and you ever have the opportunity, take a look. If the patient is willing to have you take a look, because it is worth seeing and because it is so progressive so quickly. We don't have a lot of recent data. We're looking at 2011 data, 1.6 out of 100,000 males. This does happen in women as well. Okay, so you can get this genital fasciitis. So never rule this out completely in women as well. High mortality for an infection. So this should always be on your differential list for someone who has a lot of pain, but their physical exam doesn't seem to support that degree of pain. We have listed here some typical organisms that are involved. E. coli, obviously top of the list, and some risk factors that predispose: obesity, alcohol abuse, some break in the skin. Poor blood sugar control, and some difficulty managing levels. So again, you're narrowing that differential depending on the patient's comorbidities and their history. It is characterized by a progressive necrotizing infection of the genital or perineum. And the key with this is to really appreciate that it can be much greater than suggested by what you're seeing, even on a meticulous physical exam. So this is definitely a we worry about this condition in terms of the scrotum. Signs and symptoms, again, surprisingly, not a lot of great pictures that I could find for you this morning. Painful swelling, erythema, and induration. 75% of patients present with that. Cellulitis, odor, crepitus, tissue necrosis, fever, chills, and systemic complaints, 60%. Pain that seems in excess of the visible skin changes, almost 75% of patients. That's really one of the key diagnostic things that should get your radar up. And then this idea of crepitus, the spongy crackling feeling, 50% of patients will present with that, although that's a little bit of a later sign. And by later, I mean like a few hours later. Diagnostic aids, x-rays, ultrasound, CT scan, depending on how the patient is presenting. They're going to have an elevated white count. Blood sugar may be really, really high. And ultimately, at least initially, it's a diagnosis that's based on clinical suspicion. How is this patient presenting? Therapeutic interventions are antibiotics. The process is to give you broad spectrum antibiotics before we confirm the actual organism. We want to get you started on something. We want to provide pain control, and these men or women are admitted to the hospital with anticipation of pretty quick surgical intervention. Mortality rate is 20 to 40%. This is high, right, for something. And it is heavily influenced by the time from diagnosis to the operating room. The shorter amount of time you have, better mortality rate, which would make sense. Surgical consultation can go across several services, as you see here. And there's usually extensive surgical debris and wound follow-up. And these can be quite challenging folks to manage, again, in part because their body habits can make this a real challenge to get some of these wound vacs and things to be really, really well adherent. We do want antibiotic treatment that will, as I said earlier, initially cover everything, and then we want to focus that antibiotics as we get cultures, as we get the cultures back. A lot of times wet to dry dressing, hydration, skin grafts, hyperbaric oxygen, basically just doing what we can to get this wound to heal, along with blood sugar control as appropriate. So, really, to wrap this up, what is a normal abnormal? What are the things that come into? We can't talk about everything that goes on in the scrotum, but what are the things that are normal? These are things that are common and found incidentally. So these can be epididymal cysts. They can be hydrocele can be found incidentally, and typically these would be things that are not painful or uncomfortable, and also things that are the result of some procedure. So this would be things like a sperm granuloma after vasectomy. Like, we know that that can be there, and patients can sometimes forget and self-identify that they have a lump in their scrotum, and in fact, it's a sperm granuloma from their vasectomy. Sebaceous cysts on the surface of the testicle, those don't always need treatment. Sometimes they just are there. And then certainly varicocele is not something that needs to be treated, but certainly can be treated. Just a moment here to talk about the impact of COVID on some of these things that we've talked about here. Particularly infertility, we see a lot of post-COVID erectile dysfunction. We saw orchitis, even with men who had kind of just moderate infections, not full-blown infections. So this is something that's, as we know, is still a risk and still floating around out there now. Low risk of sexual transmission. I thought I would throw this in here in case we're a urology clinic. We ask these kind of questions, right? And low risk of transition from a male to his partner. There is a risk to germ cells and Leydig cells. So those cells that are involved in testosterone production and sperm production. And we have seen evidence of impaired sperm parameters. But we think this is likely transient at this point. And so any of these effects, we're not totally sure if they are permanent. Now, some of the men who have reported erectile dysfunction post-COVID infection, that may be a little bit more long-standing and not resolved quite as quickly. These are things that we still don't know. What are the red flag things in this context that need urgent or emergent referral? A sudden onset of acute testicular pain. So again, the folks who call your office and are like, wow, I have crippling testicular pain. It's been going on for an hour. It didn't go away. They need to be seen or directed to the ER. Anyone with cellulitic or necrotic changes. So you always got to think about that Fournier's gangrene. We really want to get them into the ER and get them seen. And anybody with a complaint of a new mass or a newly painful mass in the scrotum. So someone who you know has had a spermatocele for a long period of time, and suddenly it's a lot more painful. You want to get them in and get them seen. Whether or not your individual clinic or hospital protocol supports an ultrasound and then a clinic appointment, or a clinic appointment first, depends on where you are. I have a very low threshold for ordering an ultrasound before I see you, because I think that gives us all the information for the clinic visit then. But again, your protocols may be different depending on where you are. And that's kind of a big overview summary, and I would be happy to answer questions from anyone as well as we can over video.
Thank you very much. That was great. Any questions for the audience? We're hearing great comments, but no questions. I did have a question that came in from our outside source. It's always frustrating when scrotal ultrasound comes back completely normal, but patient is still complaining of testicular scrotal pain. What would be the next step? Just tell them it's not urologic in nature, or could be from the back. Not sure what to tell these patients. So what are your thoughts?
Yeah, so I hear you. I mean, that's probably, I see half a dozen of those guys, in any given week. One of the big history pieces is, and again, whatever your licensing level is, but one of the big history pieces with them is ask them if they've ever had kidney stones, or if anybody in their family has kidney stones. So if your patient has personally had kidney stones, or a family history of kidney stones, even if he has not had kidney stones, go ahead and send him off for a UA with a reflex culture. Just make sure there's nothing to be suspicious that he's got kidney stones. Beyond that, once you've gone through all of that and really been sure that there's nothing urologic, it is challenging. These then shift into that realm of being a pain patient. That is a whole nother lecture. In short, a first step that you can recommend is anti-inflammatories. And patients will say, oh, I took Motrin and it didn't help. But they didn't take Motrin for 10 to 14 days for 24-hour coverage. And that's really the key, is you can recommend for them to take an anti-inflammatory medication for 24-hour coverage. We need to get that anti-inflammatory in the system, keep it in the system to block all that inflammatory signaling. And then if that's not successful, you really are looking at the things that cause, that are the source of the nerves in that area. So pelvic floor, pudendal neuropathy, radiculopathy from the lumbar spine. Do they have hip issues that could be radiating as testicular pain? Whole nother lecture. Happy to come back next year or do a separate uronurse for you, Vic, whatever works for you.
There we go. I think that's another good uronurse topic. Audience, I'm just going to ask you, how many, raise your hand, have seen Fournier's gangrene? So you can't see the audience, but most of the audience did put their hands up. I've had
fantastic. Yeah.
3 patients in my career. So even though it's rare, but it is, once you've seen it, you'll never forget it.
Oh yeah, you hate to say that it's very cool because it's really not great for the patient, but it is a very cool thing to see. So in our hospital, we might have 5 or 6 Fournier's patients a year. June, after COVID started and all the lockdowns started, we had 6 in the month of June.
Wow.
So there really was something to say about just routine maintenance and people doing good diabetic care. They were all diabetic patients who had terrible blood sugar control. And it was, I hate to say that we were excited about it, but it was such a good training experience for everyone. But it really was a direct result of that lockdown and people just not feeling comfortable going for routine checkups.
We're getting some chat from our online audience saying they've seen it before. So
yeah,
that was really great.
Yeah.
Any other questions? Well, Susanna, it was really great to have you on.
Fantastic.
Glad to see you again, and we'll look forward to, again, another uronurse adventure.
Yeah, just let me know. I'm available for you. You know that.